Well, good afternoon, ladies and gentlemen. Welcome to the VCCC Monday series. And I think you're going to find the session today most interesting. My name is Les Leckie, and I'm a consumer representative representing patients at the VCCC. And I've been involved there since the formation of the VCCC. First off, I'd like to acknowledgement of country, and we acknowledge the traditional owners of the land on which this event is taking place, the land of the Wurundjeri people of the Kulin Nation, and pay respects to their elders and families past and present. I think most of you know who the VCCC are, but just to remind you that the Victorian Comprehensive Cancer Centre is a powerful alliance of 10 successful Victorian organisations committed to cancer control, and specifically 7 hospitals, 2 research centres, and the University of Melbourne. The role of the VCCC is to coordinate and collaborate, which is often quite a challenge, as you can appreciate, getting all those people to work together successfully between its member organisations, and to develop a strategic program of work that integrates research, education, clinical care to maximise patient outcomes in a cost-effective manner. And remembering the reason that we're all here is for the patient's benefit. Yeah. So welcome to today's presentation. And what we've got up here on the board are some sessions coming up. And we'd certainly recommend that you put those in your diary, and we'd be pleased to see you. Hi, Amanda. Yeah. But to introduce our speaker today, Professor Fran Hall from Sydney. Fran is Professor of Medical Oncology at the Mater Hospital in North Sydney, and Medical Director of the Pam McLean Centre at the University of Sydney. She has been involved in oncology communication research and teaching for 20 years. So Fran comes to us with a wealth of experience. Today in her presentation, communicating the financial toxicity of cancer therapy, a very delicate subject, and something that's certainly been close to my heart on many occasions. And she will discuss increasing out-of-pocket costs for cancer tests and treatment, which has been termed financial toxicity. What a beautiful word, financial toxicity. Yeah. And which in turn can add significantly to patient concerns. And you can all appreciate that. Yeah. Communication in this area needs to be transparent, sensitive. At the Pam McLean Centre, they have workshopped with oncology professionals to deliver strategies to assist in these difficult conversations. Please welcome to the podium, Professor Fran.
Well, thank you very much, Les, and this is my first visit to the VCCC, so I'm enjoying snooping around. Particularly enjoying the fact that this blind doesn't come all the way to the ground, and you can see some fabulous legs walking past. And yesterday, so if I realise that you're all distracted for a moment, I'll have to do something to work on that. And yesterday I had the great pleasure of looking at lots of fabulous legs on the MCG for the Field of Women Live, which is really why I'm here this week, and watching the Swans do really quite a good job of defeating Melbourne. So pleasant to be a Sydney-sider in Melbourne today. So the area that we're going to talk about today, as Les has mentioned, is one that's increasingly a problem for us in thinking about difficult communication. And what I'm hoping to do today is to give you a flavour of some of the literature in this area, and then give you an opportunity to interact with some of the teaching materials that we're beginning to develop to help oncologists and patients talk about this area. Now, this is very much a work in progress. And some of the film that you'll see involves a really poorly paid actor playing the role of the doctor, and that's actually me. So no Academy Awards for my performance. And the reason that we have me playing the role of the doctor is that the budget didn't stretch to having a real actor. And that isn't something we would normally do in developing films. So my plan is, when we've finished with workshopping this project, we'll actually refilm it with a real actor. And the reason for that is that sometimes people are more reluctant to critique someone they know or have heard of before, or who they think is supposed to be an expert. So I want you to just put that aside and go open slather today, so that when we actually refilm it with real actors, we can make sure we're capturing the key issues. It's therefore very great to have in the audience today some consumers and also a range of health professionals from different disciplines, because our discussions about this area come to us in different ways, either through support groups, through interactions with social work or nursing. Sometimes the oncologist is the last to know that there's a problem. So I really welcome all of your input today in what I hope will be a nice interactive session. One of my co-workers in this area is Renee Lim, who's one of the other directors of the Pam McLean Centre. You'll see her later on in the film as a rather better paid actor, which she is in real life. She's an interesting person. She's a medical doctor, an actor, a director, and an educator. So she's a fantastic addition to our team at Pam McLean. So when we think about the issue of talking about personal finances, it comes into a group of what might be considered taboo conversations, where generally speaking at a dinner party, these would not be things that you would be considering. Death and disability, generally our society is not great at talking about that. Depending what kind of dinner parties you have, sex may not be on the agenda. Politics and religion, but asking people about their personal finances is something that many people who've grown up feeling that that was a very intrusive thing to discuss. And in my own family of origin, my husband's family, particularly his parents, any intrusion into a discussion about finances would be seen as very inappropriate, so particularly for that generation. Now, unfortunately for oncologists, these things are all in a morning's work. So we skip from one taboo subject to another blithely, as probably before morning tea. We'll have to have covered a number of these. And that probably means that some of us are better at it than others, depending in part on our own culture, our own family of origin, and our own perceptions of intrusiveness when it comes to raising these with patients. And we know in terms of out-of-pocket costs, there are a number of things that routinely fall through the gap. And today we're going to be talking a little bit more about unsubsidised anti-cancer drugs. And in general, there's a gap of at least 2 years between an ASCO presentation or an ESMO presentation that shows something works, saves lives, improves quality of life or survival, and a PBS subsidy. And for some drugs, it's many years more than that. I think the world record in Australia was temozolomide in brain tumours. That was in part because there were no other drugs, so it wasn't competing with anything, and because the company that was actually promoting it, its application, did a very good job of negotiating. But there are also older off-patent drugs that have become scarce or are being repurposed in other diseases and may never have been put on the PBS. And sometimes there is little incentive for companies to actually go through that whole expensive application process to get them listed when they're off patent, and others could copy them. There are also many newer investigations. PET scanning really had its epicentre here at Peter Mac, but for many parts of Australia is still hard to get. And there are many indications where a PET scan would be a great idea, locally advanced breast cancer, for instance, but the MBS application has been knocked back 3 times. Even MRI in breast cancer has been knocked back 3 times. The emerging gene profiling tests, Oncotype, Prosigna, Foundation Medicine, etc., range from $3,000 to $4,000, sometimes up to $7,000, and often need to be sent overseas for testing. A gamma knife radiation treatment to your brain can cost you $20,000 to $25,000 up front. You may get some of it back from Medicare, you may get some back on your tax, but if you don't have the MasterCard to present when you turn up for your treatment, you won't have treatment. Some of the Sursphere techniques, for instance, for liver metastases, covered by health funds, but not by the public system. And much less excitingly, but over a long period of time, much more tormenting, is treatment for lymphedema. So this is the sort of thing that many cancer survivors deal with: garments, physiotherapy and the like, generally very poorly covered by health funds, and sometimes access is completely at the patient's cost. And some surgery, in particular reconstructive surgery, prophylactic contralateral mastectomies and reconstruction, readily be $20,000 out of pocket. On our side of Sydney, if you go to the eastern suburbs, it's probably even more than that. And those, again, are the sorts of things where you might get a little bit back from your health fund, but you've had 2 surgeons in theatre for 10 hours. That's a reasonable expense, let alone anything they might implant. And when this out-of-pocket cost issue was recently measured by the Breast Cancer Network of Australia, they surveyed women around the country with a number of different profiles of treatment. So profile 1 was patients who were having just endocrine therapy and radiotherapy. Profile 2, chemotherapy as well. That didn't add much to the cost for out-of-pocket, because patients with chemotherapy usually have that as an inpatient, so it's covered by Medicare or their health funds. But the big increase in profile 3 was patients who'd had a breast reconstruction, and they were much more likely to be out of pocket. Profile 5 here is metastatic breast cancer, and it's only the first 12 months of treatment. So this is the cost within a year. Surprisingly low, on average at about $5,000, but if you magnify that by the number of years that someone's likely to have metastatic breast cancer, increasingly around 5 years, that certainly will add up over time. And not surprisingly, they found some of the areas that we've already identified were the biggest gaps. Radiation treatment in the private sector is not covered by the health funds, and many patients, of course, are shocked to discover that whilst their surgery and their chemo are covered, their radiation is not. It also doesn't include in this what we might consider as opportunity costs, so lost time at work, lost income, etc. Most of the drugs used for this group of patients will be PBS subsidised, and so that's not a major contributor except pertuzumab given preoperatively. And the metastatic profile here in number 5 doesn't include the CDK inhibitors, to which we'll return. So certainly around the country, some diversity in this. Country patients may have more opportunity costs because of needing to leave home for treatment and travel compared to someone who lives close to their hospital. Now, if that's the case for breast cancer, 4,000, 5,000, 10,000, what if you had melanoma and your oncologist had been to ESMO last year and in fact was possibly presenting at ESMO last year and showed that melanoma that spreads to the lymph nodes, which has a high chance of relapse and a high mortality, can be treated with drugs such as nivolumab, which cost around $15,000 per month, and you'd want to be skinny, really. So if you've ever thought of a motivation for losing weight, this might be what you need, because anti-cancer drugs are often given based on weight, and being skinny might actually make you cheaper to run. Dabrafenib and trametinib oral therapies for BRAF mutated melanoma around $17,000 a month for 12 months of treatment. Still waiting on the PBS with a timeline of potentially a year or 2. So what are oncologists and patients going to do in the meantime? Are oncologists going to keep this information up their sleeves and not communicate it to patients? Are they going to be telling patients at the risk of increasing their distress and needing them to take out the bank loan or mortgage their house in order to potentially improve their survival? So a very challenging time in the melanoma world at the moment. And at the MARTA in Sydney, the Melanoma Institute is our on-site collaborator with Peter Mack, and they have found this a particularly difficult year. When we think about indirect costs, these are things much harder to measure. And it's become obvious in recent times that people who have childhood cancer one would imagine their parents pay for the cost of that initially, but they themselves have poor earning capacity even as they become adults. They usually have lost time from education. They may not have had full development of cognition, and they often have chronic health problems, hypertension, renal disease, etc., with a greater need for chronic medical care. And so even in their adult life, their costs are higher. If you have disability insurance, and many people do, associated with their superannuation, there's usually a 3-month waiting time. So you have the dilemma of whether you're going to stop work for your adjuvant treatment for breast cancer for 3 months so that your disability insurance can kick in, or are you going to try and continue to work part-time during your chemotherapy to at least keep an income up during that time, but then your disability insurance won't kick in. So for many people, that's a tricky trade-off. Many of our survivors return to work part-time rather than full-time, and particularly in that first 12 months, many people find fatigue is a big issue, and it's difficult to go straight back to working 5 or more days a week. Lost educational opportunities are certainly a problem, particularly for our university students. Travel insurance, the stuff everybody loves to hate. If your cancer relapses, your travel insurer is likely to say that it's a pre-existing condition, even if it was treated 5 or more years ago. And if you haven't disclosed it, it may mean that your dream holiday has to be cancelled. And I've certainly had patients who've had to have chemotherapy organised in London, organised in Ireland, because their World Cup tour, which couldn't be cancelled, involved having to try and fit their chemotherapy around following the wallabies through the Northern Hemisphere. A real challenge to trade off what's the cost of cancelling something versus maybe delaying your treatment in order to avoid that loss. Work-related travel is often a challenge for people with lymphedema. They may not be able to go back to performing at the same high level in a job that requires a lot of travel. And increasingly, I'm recognising the financial toxicity of bucket list travel. Excuse me. Many of our metastatic patients have places they want to go, but of course insurance often doesn't cover that. And we have to try and ban people from the Northern Lights, from Antarctica, from places where expensive medical care would be required to get them out, like the US, and where they're really not going to be able to recover costs if they actually have to delay and or get out early. Loss of home executive function is particularly an issue with women in midlife. They may not just be running a business, but be running a home, and the burden of childcare, home help, care of elderly parents falls on others within the family or may need to be subcontracted out. So these things, particularly with people who work at home, nobody ever does an economic analysis of their work and what it contributes to the household income. So when we started to do some work in this area, and this goes back to 2003, which might be an important time to think about, because this was the beginning of the high-cost drugs era in Australia with Gleevec, Herceptin, some of the other targeted cancer therapies coming into use. And work done by Jackie Thompson here in Melbourne surveyed Australian oncologists, and they asked about if the cost to patients was somewhere between $20,000 to $30,000 for 6 months of therapy, how cheap things were back in 2003. If you were doing that now with a immunotherapy, it would be double at least. And they asked, would you tell your patients about this unfunded high-cost drug? And up to 40% of people said no. And the main reason for that was they were concerned about increasing distress for patients and families and a desire to protect patients, particularly if they judged that the patient couldn't afford it. And they also recognised that it was personally challenging to them to have these discussions when they knew that there was a better treatment option available and, of course, had an interest in doing their absolute best for the patient and at the same time not wanting to hand something out if it was not going to be able to afford. And Jackie published this in the Annals of Oncology, and Michael Jefford, who works here at Peter Mac, wrote an accompanying editorial which was called Paternalism. And I think I would probably try and call it maternalism now if I was writing the same editorial, because I think there was an absolute genuine wish on the part of oncologists to protect patients, not from knowledge, but from distress in this situation. So working with the consumers, we thought about how might you go ahead and change this perception going back to the early 2000s. More recently, Demi Karakios has resurveyed Australian oncologists to see whether anything had changed in that 10 years. In the past 3 months, 92% had discussed an unfunded therapy and nearly 70% had actually prescribed an unfunded therapy. So this is becoming increasingly common. It was more likely if you were being treated in a metropolitan location, in private practice, and interestingly, if your treatment was in the metastatic disease setting rather than in the curative setting. And if you think about how the PBS would judge the value of a new therapy, it's absolutely clear that a curative treatment setting carries a higher benefit when they're thinking about cost effectiveness than the metastatic disease setting. Around 15% of those discussions were initiated by the patient or one of their support people. So remember 2003, Dr. Google was not such a prominent silent member of the conversation. And the median out-of-pocket cost was much higher. Sometimes these drugs were subsidised through pharmaceutical company access programs up the top there, but in 30%, the patient met the full cost. Some were partially subsidised by private health insurers, and at our place we always have to ask the private health insurers whether they will pay so that they can refuse and then the patient can pay. But sometimes if the treatment is fairly limited to a small number of months, for instance, such as the neoadjuvant setting, insurers are more likely to pay in that situation than they are when it's an open-ended or ongoing treatment program. And very occasionally, treatment centres and cancer centres were willing to co-subsidise. Now, when Demi looked again at the reasons for concern in this situation, potential hardship to the family or their patient was still the most prominent concern in nearly all of the oncologists who responded to the survey. They commented that it was difficult for patients to evaluate benefits versus costs, and we certainly see this with all of the hype surrounding immunotherapy. For instance, there are many patients with metastatic disease who are extremely keen to have immunotherapy treatment, even though the evidence for its benefit in their disease is very small. Asking patients to make decisions isn't fair. It takes too much work to obtain funding, and it is actually quite painful, usually a whole lot more forms to fill in. So you can imagine if you were a specialist in breast cancer and you only had 5 different schemes of accessing drugs, you'd get reasonably frequently to be doing those, and the paperwork or the computer stuff would be something you would be doing most weeks. If you're in the country and you're treating 25 different cancers, each with 5 access programs, it's not hard to imagine that that would not be part of your routine daily approach to treatment. The other issue that came up was really just time for the discussion. So not only breaking the bad news about treatment being needed, but also it being unfunded. When we asked oncologists what would be helpful, one of the things that came up was a website to list access programs available for unfunded drugs. And at the present time, Medicines Australia policy actually forbids this. So there is no way under the current legislation that this could happen. The group led by John Zaltzberg has recently met with MOGA and Medicines Australia to see if that could be changed and whether MOGA, in fact, our Medical Oncology Association, might be a place that could host such a register. But at the present time, it's not permitted. a clearer understanding from private health insurance, and I think this is a general consumer concern at the present time with private health insurance, including unfunded anti-cancer drug information in the product information, cost-effectiveness analysis, and communication workshops. So that's one of the things that motivated us to continue working on trying to find some better communication strategies. This was still clearly felt to be a need. But what happens with the Australian population when you start to think about who are the community that we're going to be communicating with about these issues? And when we did some initial work with Breast Cancer Network back in 2003, we surveyed women with breast cancer and said, what constitutes an out-of-pocket cost to you for a drug? And we gave them a range from $50 a week to $1,000 a week, which was the cost of Herceptin at that time. And the answer came back, $50 a week is a high-cost drug. Probably the cost of smoking. And so we realised that at $1,000 a week or $2,000 or $3,000, we were really way off what the community thought. Recently, Martin Stockler's group from Sydney have done a cross-sectional survey of adults in Australia and asked them to rank the most important criteria for deciding on funding of medicines through the PBS. Disease severity came out on top of the list for 40% of respondents, diseases affecting children, and cancer. And so at least when we're thinking about whether the community might support us in some of the things we do, if you had a severe cancer in children, there would be a pretty reasonable chance that the community would support you in having that medicine funded. But end-of-life treatments and treatments for rare diseases actually received much less support. And again, that's a problem for people with rare cancers. And I'm sure that you'll have had a chance to speak to the Rare Cancers Alliance with the work being done here in Victoria to try and change this perception. So it is more recently, it was identified that doctors need to start developing some new medical skills, becoming better at using the stethoscope on the patient's wallet, and also becoming better at understanding themselves the cost effectiveness and cost management approaches. It was no longer something that we could just leave to the hospital administrators, but something that we needed to get involved in. The professional societies and the funders have recently all produced statements about this issue, and ASCO has launched a Choosing Wisely campaign to try and reduce low-value healthcare, so that when it comes that there is a blockbuster new drug that you want to fund, if you've stopped doing a bunch of things that weren't very helpful, the health system might tolerate that better. And interestingly, in my area, investigations for metastases in women with early breast cancer, which are apparently much more commonly done in the US than they are here, was top of the list. So the worried well who want to have a bone scan and a CT scan every 12 months are people we should be discouraging. Now the difficulty is that that cost in Australia doesn't sit in the same place as the cost for drugs. I mean, they generally sit under a hospital or a healthcare system, but drug costs in the US are an insurer's responsibility. And in Australia, they're by and large not. And so when we're thinking about how to save here in order to spend there, that equation is not as simple in Australia. They also have a value framework for assessing new anti-cancer drugs, similar to ESMO's magnitude of clinical benefit scale. And both of these give priorities to curative treatment and treatments that improve overall survival and are associated with good quality of life. WHO has its essential medicines list, and this is really designed for emerging countries in particular to focus on what are the things that are going to give them the best bang for the buck. And Cancer Australia has also started to do work in this area. Things we should be doing, let's say in breast cancer, things we should stop doing. And those are all things as a community that we need to consider. Then you have the perhaps slightly less well-informed Medicare benefits review going on at the moment. And one of the things that might happen from this that's actually a good thing is that new item numbers for oncologists for supervising oral therapies are likely to be instigated. And that might mean that the current perverse incentive to use IV chemo, so if there's a drug that works equally well IV or orally, you earn money for supervising patients who are having it intravenously but not orally. And so if you're trying to keep your cancer centre afloat, then you're going to want to give the drug IV. Once there are item numbers for using the same medications orally, hopefully that will change, because we know that patients value oral therapies for all the obvious reasons and would generally prefer to have them. And so I'm hoping that's one good outcome that might come out of what's been an extremely tortuous process. And if you're interested more in these areas, some of the references are there below. One of the things that's also changed in the last 20 years since I've been involved in the breast cancer advocacy world is better consumer input into decision making. And the consumers in the room would be aware that each of the 3 PBAC meetings per year has a time where online you can submit information, your experiences about the use of the drug, why you think it's of value, what you think it should be used for. One of those is always the first week of June, and hence almost every oncologist is not in Australia, and every Australian oncologist who is still here is working their ass off covering for other people because the ASCO meeting is on. So I'm sure that's deliberate on the part of PBAC to distract everyone in June. So if it turns out, consumers, that your drug is up for the July meeting, you really need to work hard on getting the oncologist to work with you on that, because they'll be distracted. The other 2 meetings, March, not so difficult, and November. And given that PBAC has now opened up their processes to consumer comment, if nobody makes a comment, then they're likely to think nobody cares. So if there is something coming up that's relevant, your special societies and organisations really almost need to have a strategic plan for the year ahead as to how you're going to interact with PBAC. Now, that's a big improvement on the processes 20 years ago when Herceptin was fighting it and Gleevec. And I had an interesting experience on Saturday night in Adelaide. I was there giving a talk for Belbury, which is the private ethics committee. And at dinner, found myself sandwiched between Lloyd Sampson, who 20 years ago was the PBAC chair, with whom I had a pretty tortuous relationship, and the current PBAC chair, Andrew Wilson. And both of them were reflecting on the fact that it was consumer input that had really hammered the windows, jemmied the windows open into PBS, that we clinicians really alone could not have done. That particularly was the case with breast cancer advocacy initially, but certainly has followed from others. So next, to talk about communication. And this was a comment recently from the BMJ. The old style of healthcare where sick patients could be rapidly cured and which health professionals found satisfying, and he probably means taking out an appendix or something sort of simple like that, perhaps even operating on cancer back in the day, has been largely replaced by a more complex kind of healthcare that depends on forming strong, supportive relationships with patients, and particularly over the chronic nature of a cancer journey. I think this is really absolutely true. So if we get off to a bad footing, or off on a bad footing with patients who come at their most distressed time when they're first diagnosed, if that communication around that time about their therapy and its cost goes well, then we've gained trust that's likely to benefit us downstream. And also if the team handles that well, again, the trust is likely to grow. Whereas if we do a really bad job on day one, when everybody is stressed, that is a circumstance where we may lose patients to evidence-based cancer care, more likely to be offered the vitamin C and the cannabis oil. And I didn't even include them in out-of-pocket costs, but of course there are costs and ineffective issues there. So getting it right at the beginning, or at least getting a good foundation, is very important. And bad news in the Breaking Bad News literature is defined as any information which adversely or seriously affects an individual's view of his or her own future. So it's really that future impact, cancer, of course, with its association with mortality, but also with changes in relationships and future work and earning capacity. It's associated with feelings of hope being disturbed, a threat to mental and physical well-being, a risk of upsetting an established lifestyle, perhaps more so than whether you get to the World Cup or not. And that same patient is really glad she went to the World Cup because now she can't walk from here to there without oxygen, and does at least look back on all of the time she spent going up and down in the lift in the hotel where it turned out the wallabies were staying. And so she and her husband used to actually follow them around and just travel up and down in the lifts so that they could meet people. And they still look back on that as something really special that they've done while she had cancer, now that her wings are really clipped. So we break bad news all the time, but high-cost unfunded therapies are like the double whammy. It's the second hit. It's a bad news scenario, but it's bad news for both of us. Now, when you get cancer, if I'm having a particularly bad day, I can at least go home at the end of the day and say, I did not give you cancer. You can be angry at me, you can be distressed, you can be unhappy that I'm doing a bad job, but actually I'm on your side and I didn't give you cancer. When it comes to you not being able to access the best treatment for your cancer, that's something I do feel a sense of personal responsibility about, because I may be the person who's designed the clinical trial, recruited the patients, made sure we had the right outcomes, made sure that we, when PBS was considering it, didn't lose sight of June and actually put our applications in and tried to make it happen on your behalf. So if it has failed to deliver, then I do feel responsible for that. So it's bad news for me as well. When we did the initial work with BCNA, we interviewed women with breast cancer, and they were clear that they needed to know about useful therapies. One woman said, I found out later I could have paid for Herceptin. My cancer came back and I lost trust completely in my oncologist because I hadn't been told it was an option. They weren't clear about how optimally it should be done, and they basically said, I've discussed much worse things than my finances with my doctor. Just man up and do it, really. So what did we start doing? We started working with actors and participants in workshops with this kind of scenario, and we identified two approaches generally used by oncologists. We filmed them, as I said to you, in a quick and dirty kind of way, and we've used them to try and get consumer feedback on how this material should be incorporated into teaching and whether we're actually getting the right information that we need. The patient that you'll see in this video is Linda. She's played by Renee Lim, and she works in IT, and they've been married and come back to Hong Kong where her elderly parents are living. She was diagnosed with breast cancer quite a while ago in Australia, had a mastectomy, chemo, ovarian suppression and tamoxifen, and then had a baby. She's been off tamoxifen for some time. Recently, she developed back pain after lifting her son. You know where this story is going. She's got bone metastases, which have been shown on MRI. She's been referred to the new oncologist, played by my alter ego, Dr. Boyle. And in this circumstance, her therapy could include pain relief, radiotherapy, something to strengthen her bones, but usually endocrine therapy, so not tamoxifen, but a newer hormone-blocking drug, and increasingly a CDK inhibitor, so a targeted therapy that makes endocrine therapy work better. Now, these drugs have been shown to almost double the progression-free survival, so from somewhere near a year to somewhere near 2 years, which is a fairly large improvement. However, they have not yet been shown to improve overall survival. And for that reason, and the fact that they cost a lot of money, around $5,000 a month in Australia, they were very slow to get through the PBS process. The first one, palbociclib, still hasn't got through, and ribociclib snuck around it because Novartis were more willing to do some kind of deal to make that happen. So when we made this film, we really just chose this as an example of pretty much any new targeted anti-cancer therapy where $5,000 a month would be a not unexpected cost. So the breast cancer background is there, but it's not the most important thing when you're looking at this. The most important thing is to think about how the interaction is working. As you watch the video, you're in the role of the director, seeing your daily rushes, and we want you to sit back and relax, but also think about what is it that the doctor is doing in communicating in this scenario, and whether it's working or not. So is it building trust? Is it building knowledge? Is it building a therapeutic relationship or not? What are the emotional states of Linda and her partner, Mark? And how is that relationship developing? So I'll show you a little bit of film, goes for a few minutes, and I'll then give you a chance to give us some feedback.
Okay, so what do we need to do? Well, instead of the tamoxifen, we want to start a new tablet. And there's some really good news about that, because very recently some trial results have shown that if you put 2 tablets together in this situation, you get a better result than just using a hormone blocking tablet all the time. So you might remember tamoxifen is a hormone blocking tablet, and there are some different ones that you can have. But if you add something on top of that, then the cancer is likely to stay controlled for twice as long, which I think, you know, in your circumstances is clearly a big priority with your son, is to get control of the cancer and to keep it there for as long as we can. So because it's a tablet, it's 2 tablets.
So no needle.
No, so I'm sure that's an attraction. So I might write down to be 2 tablets. One is the hormone blocking tablet, that's called letrozole, and the second one is called palbociclib, and you take them both as tablets together.
And then makes it for longer.
That's right, so twice as long, to stay under control. So I think that would be great for you to try. And the cost of that is about several $1,000s a month by the time you add the cost of the 2 tablets together.
Who will pay for that?
Well, we can check with your insurance as to whether they will pay. I'm not sure if they will, because it's quite a new drug.
Well,
How come?
that's okay. We'll work it
No,
out.
how come we have to pay?
Well, this is a new tablet, and it takes some time for the insurers to work out whether they're going to pay for it. I'm not sure what your situation is here.
They pay for it in Australia.
Well, they're looking into paying for it in Australia, but it hasn't gone all the way through the process yet.
But you say it works really well.
It works really
So
well. And
why don't they?
So
How much?
sorry, we'll need to work it out exactly for you, but it'll be several $1,000s a month.
okay, we're just going to have to make it work. We'll do it. No, but we can get it.
How? I have to stop working.
Look, I'm hoping you won't have to.
No, I don't.
I mean, okay, that you won't tell that we come over, we've been helping that out. We've been helping that. It's okay, we'll sort it out.
Well, you say they are paying me for?
No. I'm just saying that we can work something out. We're going to get the government, okay? We're going
I'm
to
not taking the money from my family.
okay, we'll find another way. That's okay. If we have to go back home, we have to go back home.
No, I can't go home because my ex.
Okay. And once you worry, I will find it. I will find it.
Where?
I don't know, but we need to get this job.
So,
Okay, what's working? Come on, some of you have been to communication school. Is anything working?
It's straightforward about the potential benefit of applying treatment, but the cost issue is huge, especially.
It is.
Mark is in perhaps
Absolutely right. So anything that the doctor was doing was being effective at communicating the issues.
Cost has been mentioned.
Okay.
Pretty good.
Simple language, effective communication.
Yep. So some of the things we learn in communication school, not using technical words, not too much jargon, and there's a nice piece of choreography in this with the thing, you know, the one on top. So when we teach people communication skills, we remind them that their body is there to help them. Anything else the doctor's doing that makes sense?
Showing genuine concern. Like, it seemed very genuine.
Mhm.
Good demonstration of empathy.
Right, so the front part was all going pretty well in that regard. Anything else you noticed that would be helpful to the patient?
She drew out a map of like the treatment options. I thought that was actually almost on the diagram on paper. I don't know if she showed the patient video, but sometimes we can actually show it in drawing.
Yes, so you're writing down the name of the drug. Previously, there'd been the picture of the spine with little thingies on it, and usually those would be things we would give to the patient to take away, particularly to explain to their family what's going on. So this person's been to communication school, except it all falls apart when we get to the money. Now, at the beginning, the doctor has said this is good news about the new cancer treatment. What do you think about that?
I was thinking when that would have been a time to say, you know, we've got this amazing treatment, however, it's not funded through the PBS. That would have been the best time to bring up the cost, because she kind of set the scene that this is amazing news that we can help, you know, manage your cancer. But left out the most important piece of information for the family.
So getting them interested in the idea and enthusiastic. Do you think Linda's emotional state improved during that time initially? So what did you see with her?
She looked, you know, pleased that there was a treatment and excited by that.
And Mark, was he starting to settle down a little bit in the early part? So in a sense, the doctor's taken the path of least resistance here, which is to make them feel better. So I've just broken a whole lot of bad news to them about the cancer's come back, and the doctor's trying to make them feel better. There's a treatment to offer, and oncologists love to do that. It's how we get through the day. You know, it's how we sleep at night. Yeah, something terrible is happening to you, and here's what we're going to do about it. So we know that plans make people feel better. We know that having some positivity and some hope makes people feel better. So the doctor's gone down the path of least resistance route to making them feel better. And then unfortunately, they drop straight over the edge. And what do you see, Len, later on with the interaction between Mark and Linda?
Very upset, very stressed, and worried about a family child. Lots of emotions coming in. He's trying to calm it down and we'll work something out.
Yeah, so he's clutching at straws in a good way. Yes.
So you use a new face of desperation, a different type of desperation.
So a new dynamic between them that had them, in a sense, separated, wasn't it?
Yeah.
Rather than
Linda
together.
was very concerned about her husband is very, very much more because she was clear
It's also where the money's coming.
Where's the money going to come from? So you've got to remember Mark's grown up in Australia. So most Australians have an enormous entitlement complex about their healthcare and really do think that somebody else should be paying for it and really just figure that's the way you just need to work that out. Most Chinese people don't grow up thinking that. They grow up thinking that you're actually responsible for, you get what you pay for. You may have insurance or you may not, but you don't grow up feeling entitled to having healthcare. And so there may be some cultural differences coming into this conversation as well. So you made one suggestion about how it could be done better, which was to talk about the money very early. Any other suggestions that people would have as to try and take a path of perhaps more resistance, but that might end up in a better place?
Well, the thing that hit me most, I worked as a consultant, is there was no end in sight. And that, the $3,000 per month with no guarantee that if there was a comment made, it would enable you to keep the family going for an extended length of time, but there was no end in sight. That was what hit me most.
Yes, so it wasn't, it's 6 months of treatment and they get to you X, it was pretty open-ended, wasn't it? So she doesn't know how long she's going to be paying that. So that's a very good point. Behind you, had a comment? Any other suggestions about what the doctor can do?
You mentioned earlier in your research that oncologists weren't routinely asking patients because there was that presumption that they wouldn't be able to afford it. So the very fact that the doctor put the cost forward, I thought was a move, a positive move, because they weren't making that assumption and putting their own perception onto the conversation. And it was positive until then, but then the lack of ability to mediate that relationship, that's where it fell short. It seemed to me, you know, the doctor was comfortable talking about things that they were confident talking about and knew about, but when it came to that kind of personal relationship and that the unfamiliar topic coming through, the doctor really backed off. And possibly that was an opportunity to have other communication skills come into play to mediate that conversation in some way, and offer an endpoint as well, not necessarily a financial endpoint or a treatment endpoint, but an endpoint to the struggle.
Yes, so the referee was not doing a very good job and basically went back and sat on the sidelines and kind of went, well, it's your problem, not mine. So you see this withdrawal happening. So they're not a team anymore. The two of them are not a team and the doctors are not the team either. So you're right. I think there was, let's get it out there, and then, ooh, wish I hadn't done that. All right, so here's number 2, and see if you think any of this is working better.
So what do we do? Well, I think the first thing we need to do is to get your pain under control, because everything will become easier to manage if we can get you feeling better. So I'm going to suggest some medication and also some radiotherapy. And I know that sounds tough, but I think it won't be as tough as the radiotherapy.
You say it's not as long?
No, I think a short time, just a small number of weeks.
Okay.
Then what I think we need to do is to get some hormone blocking treatment back on board. And there are some newer drugs that replace tamoxifen when you're a little bit older. You can take those. And they reduce the estrogen in the body. And that helps to make those cancer cells go dormant again and put them back to sleep. That don't go away. Well, some of them will go away, for sure. But I think they won't all go away. So we need to keep the treatment going rather than just use it for a short time. So that's a tablet called letrozole. And I think you will be fine taking that. We also want to make the bones stronger, because that will help with the lifting of Charlie. And there's a medication that we can give you, and that's called I'll give you this because these ones are really helpful, and I think you probably want to look them up. So those are the 3 things that we would do straight away. And I've already said we're going to do some scans before we start, so we've got a complete picture of everything. Okay.
So for the pain and back to help with cancer.
Now, those are all things that we've had available to us for some years now. We have some idea of how that would go for you, and that's not the only treatment, but it's still really begin. There are also some newer treatments for breast cancer that add on top of these things. Is that something you'd like to hear about? Okay. So they are quite new, and for that reason, they're also quite expensive because they've taken a lot of time to be developed. Really expensive. Really quite expensive. So several $1,000s a month. A month. For us to pay. You would check with your insurance because they may pay some and we may be able to get some help with access. But one of the things about these treatments for many people is that they're really expense is a big factor in making a decision. Sorry, that isn't something you need to decide today. It isn't something that you need to decide right now. Because we've got all these other things we need to do in the meantime. We can get all of that rolling and get you feeling better. Okay. And that gives us a chance to talk to the social worker, talk about your insurance, and maybe your family would be willing to help. I don't know. Maybe that's an option. Well, I think this news is going to be difficult for them anyway. So maybe we should just get through this early bit and then we can explore.
But and you treat this treatment anyway, right?
All of these things are treatment. Yes, so I'll write down the name of the medicine and you might want to look that up as well and we can give you some information about it. Yeah. But I think it's something.
Okay, so in the interest of time, we'll stop there. So what's different about the second time round?
Immediately going into clinical quality of life improvement measures, your mentioned really whether there was an out-of-pocket cost for that, there might be. Okay. Following what in the exercise that this pill straight into cells so much for a while. It's remarkably honest and frank and honest about that particular treatment. And then you move on to a very specific treatment, and then after that, then talking about the new and expensive treatments. And yes, there's this issue of what expensive means to the oncologist and what it means to the patient. And there's a big gap there between definition of expensive. But what was good about that, I would say that, is that you emphasize that we decided on today, and then the discussion intercourse with the insurance company. At which point I'd like to say, Brad, that both in the first presentation and the second, the word insurance has been presumed to be valid, but many people in Australia to this day still don't have health insurance. They look to Medicare to be their main stay. And should we always assume that this particular couple would have health insurance or Medicare?
Well, they're living overseas, so in that circumstance, people sometimes have, it's a foreign context.
Yeah.
So people who have different countries they live in may have to have international insurance as part of their work. Yeah.
And sometimes they've got insurance schemes and there is. So that's another issue. I just had to check the national context.
Yes. Yeah. So your thought about bringing the cost up front before talking about really anything much to do with how the drug worked, do you think that worked better?
Yeah. Otherwise, you're leading somebody to a beautiful faraway land and then saying at the end of it, by the way, you can't.
Yeah, where's your gold MasterCard?
Yeah, I thought it was really simply concentrating early on the things that could actually be very active treatments, doing the pain, but that would be very, very important treatments, rather than just sort of dangling a big carrot initially and then taking it away. Really showing what could be done.
Right.
Providing some more rarefied options that will longer going to be in the region describing it.
Yes. So what we call this Pam McLean Centre, having been experimenting with it for a long time, is the cupcake model of high-cost therapies. And it is suggested that you start discussing standard therapies, including their costs. So radiotherapy, of course, may have a cost in this context, and denosumab and letrozole are not so cheap either, before offering to discuss unfunded therapy. So in the second scenario, the doctor said, would you like to hear some more about that, rather than just kind of leaping straight into it. Expecting it to take some time for the realisation to set in and for there to be an emotional reaction. Whether that's distress, anxiety, disbelief, etc. And most of the work we've done with Breaking Bad News suggests that it takes a couple of minutes for that to happen. So it is going to take longer because people need to process, what does this mean for me? Offer support that's empathic and offer delay of decision. It is very unusual that this is like appendicitis and has to be treated today. That would be most unusual in the cancer context. And usually there is time to think about what the options might be. Over the last few years, we've seen people use superannuation, sometimes insurance, community fundraising, the GoFundMe page on Facebook, compassionate access programs, and also purchase overseas. So when palbociclib was first on the market in Australia, it was about half the cost in Malaysia. And so patients would fly to KL, get their treatment organised there and fly back, and that was still cheaper than buying it in Australia, which is ridiculous, but there you go. How to talk about the money is very important, and this speaks to the issue that the gentleman with the green shirt raised, is that you need to work out what the total cost might be if all the therapy is given, and you need to therefore know that the average duration of treatment from this clinical trial, so the median was 2 years. It's a very long time. And then cut it down to weekly or monthly costs, or a cost per dose or cost per cycle. Because someone who has an anaphylactic reaction to dose 1 is dumb to have bought 6. So if it's a drug that causes anaphylaxis, you should always buy them one at a time and not actually buy, half a dozen, even if that's a cheaper way to do it. So pay as you go is the expectation, because many patients won't actually need the whole of the treatment or won't be able to tolerate it, and so therefore may have their treatment curtailed. And when the patient comes back, of course, and is in a better frame of mind, hopefully, because she's not in pain and terrified, discussing their values, which might include prolonging her survival as long as possible with a small child, but also her quality of life to allow her to work, and how to save money for the family's future. So families will sometimes say it's more important for her to pull her superannuation and pay off the mortgage because she's not working, than it is for her to pull her superannuation and spend it on a drug. And that's what she might be thinking, whereas the husband's thinking, I just wanted to stay alive. So they've got to sort that out, and that's where having a social worker or a psychologist involved as part of your team to help them clarify what they want to do can be really helpful. Some other hypothetical scenarios that we have thought about whether they would be useful to film and to use in education is, what if a high-cost therapy improved cure rate, not just longer disease control, and would people feel differently about it? What if it was the therapy that improved quality of life but not survival? What if there was no useful standard therapy to offer? And this was Gleevec in GIST in 2003. And what if there was little evidence of benefit, but nothing else left to try? So the Keytruda last ditch, as it were. So hopefully, if we can improve communication in this area, we can increase understanding and trust, but also the information our patients retain. Adherence is really critical. If you spent $5,500 on a bottle of tablets, you want to know how to take them properly. Collaboration with the treatment team and autonomy, so that patients are able to make good choices, but also potential for advocacy, because sometimes the best advocates for a new therapy are the people who are actually benefiting from it. And they are the ones who may have the most powerful voice when it comes to talking to the PBS. So I'll stop there, slightly over time, and see if there are any questions.
Well, ladies and gentlemen, what a wonderful presentation. And I think one of the most stimulating ones that certainly I haven't been to on a Monday VCCC series. So congratulations. Well done. We've run over time, but any quick comments from the audience? Very quick. Okay. No, there's none. All right. Well, again, would you thank Fran for a wonderful presentation? Thank you.